Hi, and welcome to Rosie the Riveting RN. Today I'm going to go over a chapter in a nursing school textbook, and I'm going to teach you how to go over the text and hopefully not get overwhelmed with information. So, the text that we're going to be going over today is the same text that my students use, and that is the Lewis Medical Surgical Nursing text. It is the 12th edition as well. So here we go. We are going to go over chapter 62, which is stroke. It's a pretty big chapter, but I'm going to help you navigate through it. So basically, what I want my students to do, I want them to take the text by paragraph by paragraph. That way, it's not so overwhelming. So let's take the first paragraph together. As you can see, I already highlighted stuff. I actually recorded a video on this chapter, but unfortunately, it did not save. So I'm just going to go over the highlighted points with you guys today. So, what is a stroke? Stroke occurs when there is ischemia, which is inadequate blood flow to part of the brain, or hemorrhage, which is bleeding into the brain, that results in the death of brain cells. In a stroke, functions such as movements, sensation, thinking, talking, or emotions were controlled by the affected area of the brain are lost or impaired. The severity of the loss of function varies based on the location and extent of brain damage. So basically, what is that telling you? That's telling you that a stroke is either caused by inadequate blood flow or bleeding to the brain. Either way, they're going to have neurological deficits and they can have emotional liability. Or be emotionally liable. The next paragraph, so the terms brain attack and cerebral vascular accident, or CVA, are also used to describe stroke. The term brain attack communicates the urgency of recognizing the warning signs of a stroke and treating it as a medical emergency, as we do with a heart attack. After the onset of a stroke, immediate medical attention is crucial to decrease disability and the risk of death. So basically, what it's saying is that a brain attack and a cerebral vascular accident, they're the same thing. They're both urgent in as far as time and getting the patient treated as fast as possible. So that's kind of how you want to look at each paragraph. What is it saying, and what's the biggest takeaway? So I'm going to go over the highlighted areas. So basically, a stroke, it is the leading cause of serious long-term disability. Some of the signs and symptoms are going to be that hemiparesis, which is partial paralysis on one side, inability to walk, complete or partial dependence for activities of daily living, also known as your ADLs, aphasia, dysfunction in communication, and depression. In addition to physical, cognitive, and emotional impact of the stroke on the survivor, the stroke affects the lives of the stroke patient's caregiver and family. A stroke is a lifelong change for both the stroke survivor and the family. Be mindful of this impact when caring for patients who survive a stroke. So basically, what that paragraph breaks down to is that the signs and symptoms are partial paralysis on one side. You have the inability to walk. You can have complete or even partial loss of independency of your ADLs, and it can cause depression and quite a bit of emotional changes and affects even the family and the caregivers. So, as you're going through the textbook, you are going to have these various tables. Now, the tables are really great at condensing the information that is being taught in the textbook. Please know that that doesn't take away the fact that you do need to read the text, because the text will provide more information. It's just that this is going to be condensing that information. So these are your warning signs of a stroke. We all know the FAST warning signs, which is facial drooping, arm weakness, speech difficulties, time. Time is critical. The longer the patient goes without treatment, the worse the prognosis is going to be. So when I teach my students, because they're in the med-surg phase of their learning, they already had quite a bit of anatomy physiology. They already had a lot of pathophysiology, as well as their assessments and foundations in nursing. So it is important to know the basics of the anatomy and what actually causes a stroke, how it happens, but it's not really necessary to go into a whole lot of debt. What we're going to be focusing on is what are you going to do as a nurse? Can you recognize that, yes, this is in fact a stroke, and what are you going to do as a nurse? So, the biggest takeaways that I had from this section of the text is that there's a term that is known as cerebral autoregulation. This is where there's changes in diameter of the cerebral blood flow vessels, and this can actually affect the cerebral blood flow, which is basically blood flow to the brain. Right? The cerebral autoregulation affects the cerebral blood flow because of how much the vessels are dilated or constricted. Changes in cardiac output, vasomotor tone, and distribution of blood can be affected by this as well. The blood viscosity, how thick the blood is, can also affect the cerebral blood flow. We do have what's called collateral circulation, and what that is, it's basically the body's way to make an alternative route for blood flow. One thing I do teach my students is that, yes, this is a great thing for the body to adjust to. However, you want to think of new vessels kind of like a sequel to the movie. The original or the sequel is never as good as the original. The sequel is going to be weaker. It's going to be much more of a risk for bleeding, and it's just not as efficacious as the original vessel. So that can lead to quite a bit of issues as well. Intracranial pressure also influences your cerebral blood flow. Increased ICP causes brain compression, and it decreases that blood flow to the brain. So those are good things to take note of. Moving on to risk factors. Now, modifiable risk factors, non modifiable risk factors have been just drilled in your brain, and you're very well aware of what those are if you are at the med-surg level. So, I'm going to take this pretty quick for you guys. So, our non modifiable risk factors, those things that cannot be changed. That's going to be your age, gender, ethnicity, family history, and so forth. We do know that African Americans are twice as likely to have a stroke and mortality from a stroke. We also know that women do tend to have more higher risk of mortality from a stroke, and that can be just because we tend to live longer than our male counterparts. Modifiable risk factors, those are things that we can change. That's going to be stuff like controlling hypertension, heart disease, diabetes, smoking, sleep apnea, metabolic syndrome, lack of physical exercise, poor diet, and drug and alcohol use, whether that is legal drugs or not. So, hypertension, it is the single most important modifiable risk factor. So, that is a good to know. If you do have hypertension, you're at a very, very high risk of having a stroke. Our goal for patients for hypertension is to have a systolic blood pressure less than 140. So, that's something that we're going to aim for with our patients. Other dysrhythmias can be a cause to, or even a risk factor to having a stroke, and that can be AFib, that can be cardiomyopathy and enlarged heart, that can be cardiac valve abnormalities, and even congenital heart defects. Diabetes is another modifiable risk factor. The reason why it's modifiable is because we can treat diabetes, we can control diabetes, and we can have good glycemic control. Those are things we do have control of. So that's why that's a modifiable risk factor. Smoking is a choice, so that is considered a modifiable risk factor, as well as alcohol use and even illicit drug use. Those both increase your risk of having a stroke. Obesity increases your risk of having a stroke. So, what are we going to advocate for? And as you go through the textbook, you can use different color highlighters. As far as like what your education is going to be. And education, that's a huge part of your nursing job. That's a huge part of your job. So I teach my students that the best medication is patient education. So you do want to get in the habit of learning how to teach and talk to people basically who are on the 12th, like they're 12 years old basically, because the national reading average is going to be that of 6th grade. That's a 12-year-old. So keep it simple. So what are we going to encourage our patients to do? 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. We also know that diets that are high in fat and low in fruits and vegetables also increase your risk of obesity, which increases your risk of having a stroke. So, some birth controls can increase your risk. They used to, at least. We do know that newer low dose oral contraceptives have a lower risk for stroke, except for those who have hypertension and those who smoke. So if you're on an oral contraceptive, we want to control your hypertension and we need you to stop smoking. Also, who's at a risk factors are patients who have migraines. The reason why that is considered a modifiable risk factor is because hopefully we can avoid our triggers and we can decrease the occurrences of those migraines. Now we go into another little form of a stroke, and that is a transient ischemic attack. This is basically going to be your mini attack, your mini stroke, I should say. So it does cause, it's of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia, but it is without acute infarction of the brain. What does that mean? You're not going to have a full blown stroke. You do have some type of ischemia in one part of the body. It can be the eyes, it can be a certain part of the brain. It's very small and minute. It's not going to be manifesting like a traditional stroke. So it's like a mini stroke. There's no way that we actually can predict how this is going to affect the patient. They might have another TIA, they might have an ischemic stroke, they might have nothing happen. So, some patients do have this and they don't even know that they have it. Other signs and symptoms are going to include darkened or blurred vision, diplopia, ptosis, dysarthria, dysphagia, ataxia, and unilateral or bilateral numbness. A TIA is considered a medical emergency since it can lead to ischemic stroke. And of course, if you do have signs and symptoms, go to the hospital or call 911. Now, this is where the book goes into the two different types of stroke. First, we're going to talk about an ischemic stroke. Now, there's two types of ischemic stroke. There's thrombotic and there's embolic. So, thrombotic stroke is injury to a blood vessel wall and formation of a blood clot. It happens in vessels where plaques has already narrowed the blood vessels. Thrombotic stroke is the most common cause of a stroke, and this can be caused by high cholesterol, atherosclerosis, or diabetes. Hypertension or diabetes, both of which accelerate atherosclerosis, can definitely increase your risk of having an ischemic stroke. Usually, these patients do not have a loss of LOC, that is level of consciousness. So, usually, they do not have decreased level of consciousness in the first 24 hours unless it is due to a brainstem stroke or other conditions such as a seizure. And this increases your ICP or there's a hemorrhage. Even after a stroke has been identified, we get them started on medications. This can still progress and get worse even 72 hours after the stroke has happened. So you're still doing your neurovascular checks with these patients. Next one is going to be an embolic stroke. This occurs when an embolus lodges in and occludes the cerebral artery. So basically, an emboli breaks off and it goes to the brain. The embolus travels upward to the cerebral circulation and lodges where a vessel narrows or bifurcates, meaning that it splits. Stuff like AFib, MI, infective endocarditis, valvular heart prosthesis, patent foramen ovale, and atrial septal defects can cause most embolic ischemic strokes. Other causes can be an air embolism or even a fat embolism as well. So these are good to know. Warning signs are less common in embolic stroke than thrombotic strokes. There's more warning signs with thrombotic strokes. Embolic strokes, they occur rapidly, giving very little time to accommodate an obstructive blood vessel by developing collateral circulation. So basically what this is saying is that this occurs far more rapidly than a thrombotic stroke. The reason why is because the body doesn't have enough time to develop those collateral circulation, which is those alternative routes or new vessels that go around the occlusion. So as you can see here in the text, it has these pictures. So a thrombotic stroke, there's already plaque built up in the vessels. And what happens is a blood clot gets dislodged and it gets stuck behind this plaque, and that causes a stroke. With embolic strokes, there's no plaque. It's just it's going to be a clot that does get dislodged. Usually this happens in areas where there is a bifurcation. And then this is an illustration of a hemorrhagic stroke, which is basically a bleed. There's a rupture of a vessel. So prognosis is related to the amount of brain tissue deprived of its blood supply. So those are good to know. Now let's look at what is a hemorrhagic stroke and how to break up that information. Hemorrhagic strokes result from bleeding to the brain tissue itself. It is a rupture of a vessel. There is a 30-day mortality rate that is 40 to 80%. Half of the deaths are going to occur within the first 48 hours. Hypertension is the most common cause of a hemorrhagic stroke. This is sudden onset of symptoms and it progresses over minutes to hours. Your manifestations are going to be neurologic deficits, headache, nausea, vomiting, decreased level of consciousness, hypertension. So there's some parts of the brain where there's going to be different types of manifestations. So in the cerebral lobe, cerebellum, pons, thalamus, subcortical white matter, in internal first, patients have a severe headache with nausea and vomiting. So either way, they're going to have a headache, they're going to have nausea and vomiting. They're going to have weakness of one side. This includes the face, arm, and the leg. So from head to toe, they're going to have weakness or even paralysis, loss of sensation. They can have slurred speech and deviation of the eyes. They can have hemiplasia, fixed and dilated pupils, abnormal body posturing, sensory loss. They have more sensory than motor loss. Problems with vision and eye movement. Again, there's that severe headache and vomiting, loss of ability to walk, dysphagia, dysarthria, and eye movement changes. So those are good things to know as far as what a hemorrhagic stroke looks like. Now there is a subarachnoid hemorrhage. This is basically where the subarachnoid space is going to have the bleed. So this is often caused by an aneurysm. Other causes can be trauma or illicit drug use. The patient may have warning signs and symptoms with the ballooning artery. That's the reason why is because it can put pressure in the brain. But this is known as a silent killer. An aneurysm is known as a silent killer. There is loss of consciousness that can occur. Patient's LOC may range from alert to comatose, depending on the severity of the bleed. Other manifestations include focal neurologic deficits, which include cranial nerve deficits, nausea, vomiting, seizures, and stiff neck. Now, complications. These are always good to know. What are your complications of a disease? Complication of a SAH caused by an aneurysm is rebleeding, and that rebleeding can happen even before we get them started on any treatment or we go into surgery. Vasospasm is also a complication for your SAH strokes, but vasospasms that can happen 6 to 10 days even after the initial bleed. So you're still monitoring the patient pretty closely. So let's take a look at some of our notes. How do we break this down? So the way that you want to break it down, what is it? It's either ischemia or hemorrhage. A brain attack, CVA, it's the same as a stroke. Either way, it's urgent, right? It is the leading cause for long-term disability. You have your non-modifiable risk factors, modifiable risk factors, and you can write those out. ETOH, that is alcohol, so you can kind of do shorthand. PA, that's physical activity. Your signs and symptoms. So that those highlighted signs and symptoms you can start to write down. So that delta, that's a sign for change. That's shorthand for change. Change in personality, decreased sensation, poor swallowing or ineffective swallowing, decreased affect, all that stuff. And then we went over TIA, that's a mini stroke, right? This can happen in certain areas and we can note those down. There's no infarction of the brain. That is what is specific for a TIA. There's no infarction of the brain. And then we can take note of what their signs and symptoms are. If there are those signs and symptoms and you know you're having that, it is a medical emergency. Call 911 or go to the ER. And since we just looked at the differences between an ischemic stroke and a hemorrhagic stroke, this is how we would do our notes. So I like compare and contrast tables. So there's an ischemic stroke. You can have partial or complete blockage of a vessel. It can be thrombotic or embolic, right? And you can take note of what the differences between the two are. What is a hemorrhagic stroke? That's a brain bleed. It is a rupture of a vessel. It can be caused by an aneurysm. There is a very poor prognosis of a brain bleed. So signs and symptoms, headache, nausea, vomiting, decreased level of consciousness, hypertension. That hypertension, that is like the leading cause for a hemorrhagic stroke. Vision changes, mobility impairments. Again, these complications, rebleeds, vasospasms. So you just took all these pages of notes and you condensed it to this. You make it easy for you to comprehend. You don't have to rewrite the textbook. So let's go over some more clinical manifestations. So one thing to know, there's going to be very specific differences between the right side of the brain and the left side of the brain when there is damage. And those you actually do need to know as a nurse because that is a part of your assessment. So some other signs and symptoms of a stroke that can be affecting really any body function, including motor activity, bladder, bowel function, intellect, spatial perception, and we can go into more detail with that. Of course, your motor function can be affected, communication. You can have poor affect, for poor ability to show emotions. Now, this is a really great chart to look over. So, the right side of the brain, they're going to have hemiplegia of the left side. You have a right sided stroke, you're going to be seeing those manifestations on the left side. You have a left sided stroke, you're going to see those manifestations on the right side. So you have left-sided neglect, spatial perceptual defects, or deficits, I should say. Tends to deny or minimize problems, rapid performance, short attention span, impulsive safety problems, impaired judgment, impaired time concepts. Now, someone with the left side, a left-sided stroke, they're going to have hemiplegia of the right side. They're going to have impaired speech, language. Remember, left language. Impaired right-left discrimination. Slow performance. They're more cautious. They are aware of their deficits. They do have depression and anxiety. And then they can have impaired comprehension related to language and math skills. So those are some things that are some good to know. There's a lot of good to knows. I know, it's a lot. I say it too much, sorry. So let's get this camera a little bit better focused. So this is the first one I'm doing, so there's going to be a lot of trial and error with this. So patients can have impaired mobility, respiratory respiratory function, swallowing, speech. They can have a poor gag reflex, and self-care abilities can actually be lost. So the characteristic motor deficits include loss of skilled voluntary movements, that's akinesia, impaired integration of movements, changes in muscle tone, altered reflexes. They can have hypoflexia followed by hyperflexia. So we're going to first see the patient have hypoflexia. They're going to be flaccid. And then it can then their body can go, or at least the affected side can experience hyperflexia. That can also be known as spasticity. That can possibly show us that there's going to be some form of recovery in the patient. There's going to be a stroke affecting the middle cerebral artery leads to greater weakness of the upper extremity than the lower extremity. The affected shoulders tend to rotate internally and the hip rotates externally. The affected foot is plantar flexed and inverted. The initial period of plasticity may last several days to several weeks. From days to several weeks. It is related to the nerve damage. Muscle spasticity follows the flaccid stage. So these were my biggest takeaways from this paragraph. So communication can definitely be affected in these patients. And what are we going to see? There's different types of aphasia, and you do need to know the different types of aphasia because you need to figure out how am I going to communicate with this patient, right? So aphasia, that is basically like the impairment or loss of speech. So there is receptive aphasia, that is a loss of comprehension. Expressive aphasia, that is inability to produce language. You're unable to express yourself with language. Global aphasia, total inability to communicate. So you can't talk, you can't write, all that stuff. Aphasia occurs when a stroke damages the dominant hemisphere of the brain. Dysphagia refers to impairment ability to communicate. However, in most settings, the terms aphasia and dysphagia are used interchangeably, and that's absolutely true. Many stroke patients have dysarthria, the problem with muscular control of speech. So they might have the actual ability to produce speech, but they lack the muscular control to actually use their tongue and their mouth to produce those appropriate sounds. And that's where we get those slurred speech that can be really hard to understand. So then we need to figure out how can we best communicate with this patient and how can they best communicate with us. Affect, that's a hard time controlling their emotions. They can have they can be exaggerated or unpredictable. They can definitely have depression, and this is related to changes in their body image, loss of function. It can be loss of the role that they take in the family. They're no longer the breadwinner that they used to be, and that can be just really frustrating for the patient. Okay, so then these tables here, it breaks down the different types of aphasia as well, and these go into really good detail. Again, the tables, they do not take away the fact that you do need to read the text. It's just going to add and condense that information for you. So, intellectual function. So, a stroke may impair memory and judgment. These impairments may occur with strokes affecting either side of the brain. A left brain stroke is more likely to result in memory problems related to language. Patients with a left brain stroke often are cautious in making judgments. So, it's good to know that stuff. So, for example, a right brain stroke tends to be more impulsive. They try to rise quickly from a wheelchair without locking the wheels or raising the footrest. On the other hand, people with the left brain stroke would move slowly and cautiously from the wheelchair. So those are good things to know. Now, what does it mean when we say spatial perceptual problems? Basically, what that is, that's an incorrect perception of self and illness. It could be spatial neglect. This occurs when the patient neglects all input from the affected side. This may be worsened by homogeneous hemianopsia, which is they're blind on the affected side, and they can't see like on one side of their body. Agnosia, that is going to be the inability to recognize an object by sight, touch, or hearing. Apraxia, this is the inability to carry out learned sequential movements on command, like actually doing methodical movements, hearing the commands, and executing the commands. So that can definitely happen. Elimination problems can happen in our patients. So they might be incontinent. There's times where they can be constipated as well. So we want to make sure that we are going to be doing scheduled toileting and that we have them in clothes that are easily removed, and that can encourage independence so that they're not frustrated with trying to take off like a button on their pants or take away that independence. So diagnostic studies. Some people, they kind of glaze over this. These are really important to know because knowing how to recommend some types of imaging and diagnostics, that's one way that we can actually advocate for our patients. So when you do ask a provider, like, hey, can we do a CT scan? And they're like, well, why? You want to know the reason why and like what exactly you're going to be ruling out. So, for a diagnostic study for stroke, it's going to be non-contrast CT and MRI. Other ones, we can do CT angiography, that is visualization of the blood vessels. Of course, we do need to get that blood pressure pretty stable or relatively stable. We can do magnetic resonance angiography, and that can detect vascular lesions and blockages. We can do cardiac imaging like an echo to see if there's any structural issues or blood clots in any of the valves or the chambers. Angiography, this can identify cervical and cerebral vascular occlusion, atherosclerotic sclerotic plaques and malformation of vessels. We can also do a cerebral angiography or even a DSA, a TCD, and an LP. Our biggest one that we're going to do is a CT or an MRI, no contrast. That's what we're going to do. We can do a lumbar puncture if we do suspect that there is a brain bleed. We're going to be doing a lumbar puncture to see if there's any blood in the cerebral spinal fluid. So let's go over our notes, right? So we took all of that information and we broke it down into this page. So other signs and symptoms, we do take note of that it's akinesia, hyperflexia, contralateral neurodeficit, spasticity occurs after the flaccid period. And we can talk about like the middle cerebral artery, what that looks like, and so forth. Left language. I like to know certain tables that I can reference back to, and then certain pages that I can reference back to if needed. So noting the different types of aphasia, I can go back to this page and be like, okay, this is what receptive is, this is expressive, if I forget what each of these are. Poor emotional control, they can be unpredictable, depressed, they can have memory and judgment impairment. And then you can also do a compare and contrast table, the differences between a left-sided stroke patient and a right-sided stroke patient. You can highlight the differences that are like the biggest takeaway. Your diagnostic studies, CT, MRI with non-contrast. The reason why I put a star there is because that's the main one that we're going to do. We can do all these other ones, but this is your meat and potatoes. Also, we can go into preventative care, which is what is the next topic. And basically, if you have a TIA, we're going to get you started on baby aspirin, which is 81 milligrams. We can also do Plavix, Persanidine, and we can do Agrinox as well. A good thing to note, if you do have any of these drug alerts in the textbook, read them. These are things that we're going to be assessing for or educating our patients for when they start to get discharged. Other types of anticoagulants that we can do, that can be Coumadin, warfarin, which is warfarin. We can do Xarelto, Pradaxa, Eliquis. What's nice about Pradaxa, Xarelto, and Eliquis is that we don't have to do any like dosing blood draws. Other medications that we can do to be preventative therapy of a full-blown stroke are use of statins, because that atherosclerosis increases your risk of having a stroke. We can do something that's called a left atrial appendage. Basically, this is a pouch that extends off the left atrium. We think the LAA is a source of many stroke-causing emboli in patients with AFib. Removing or occluding the LAA decreases the risk of strokes. So that's something that we can do for patients. Other things that we can do, if they have a patent foramen ovale, we can occlude it. So occlusion device implanted in the opening can prevent clot dislodgement. We can do stents for patients in an angioplasty to prevent any further stroke. So those are things, and that's how I have broken down that information to really condense it. So hopefully this is helping you and it's not overwhelming. I know I tend to talk a little fast. I'll try and work on that. So what are we going to do for patients with a stroke? So in your text, when it says acute care, basically hospital care. It's right now care. So during the initial evaluation, the single most important point in the patient's history is the time and onset of symptoms. Care goals during the acute phase are preserving life, preventing further brain damage, and reducing disability. We want to really take note of this table here. And these are standards that are set by the American Heart Association. This is the door to needle time intervals. So basically, what this is saying, patient comes in with a stroke in less than 10 minutes, we want them to see an ER physician. Less than or equal to 15 minutes, they're going to see the stroke team. In less than 25 or equal to less than or equal to 25 minutes, they're getting their CT and MRI done. And in less than or equal to 45 minutes of arriving in the ER, we are getting that interpretation done by a radiologist. In less than 60 minutes, we're getting them started with medication. And this does improve prognosis and in the livelihood of the patient. So those are things that we are going to shoot for. We're moving really fast, and this just further indicates time is completely of the essence with a stroke. So, and that basically breaks down all of this. I'm going to skip over to medication. So, fibrinolytic therapy should not be delayed. Recumbent use of plasminogen activator, which is TPA, is used to produce localized fibrinolysis by binding to the fibrin and the thrombi. Basically, if you have a thrombolytic or an ischemic stroke, we're giving you TPA. But there's things that you do need to know. We can give TPA, but it must be given within 3 to 4.5 hours of onset of signs of the ischemic stroke. We must screen patients carefully before they receive TPA. Screening includes non-contrast CT scan or MRI to rule out a hemorrhagic stroke. Blood tests for coagulation disorders, screening for a recent history of GI bleeding, stroke or trauma, head trauma within the last 3 months, major surgery within 14 days, or recent active internal bleeding within 22 days. So if you have any coagulation disorders, if you have history, recent history of a GI bleed, you have a stroke or head trauma in the last 3 months, major surgery in the last 14 days, or you had recent active internal bleeding in the last 22 days, we cannot give you TPA because that is going to cause you to have a bleed. We can do what's called intra-arterial TPA, and that can be given within 6 hours of onset of stroke symptoms. Basically, what we're going to do like an angiogram, and we're going to put a very small dose of TPA at the site of the clot, and it completely dissolves it. We can give aspirin at higher dose that can be started within 24 hours after the onset of ischemic stroke. Complications of high dose aspirin, of course, is going to be your GI bleed. So you're going to be monitoring their poop, right? Are they bleeding? So after they're stabilized, we can start them on warfarin. We can do Xarelto, Pradaxa, Eliquis. Platelet inhibitors include aspirin, ticlopidine, clopidogrel, and dipyrimetal. I suck at saying medication names. We're also going to be doing statins because if you remember, an ischemic stroke, it can be a thrombotic, which involves plaque. So, what are we going to do for a hemorrhagic stroke? It's going to be very different. All of that was for an ischemic stroke. This is going to be for a hemorrhagic stroke. So, drug therapy with a hemorrhagic stroke involves managing hypertension. We have to manage hypertension. Hypertension is the likely cause for a hemorrhagic stroke. Therefore, we need to control it. Our goal is to have an SBP, a systolic blood pressure, less than 160. Because of the brain bleeding and swelling that's occurring in the brain, we need to put them on seizure precautions and we need to put them on seizure medications. So they're going to be given IV to the patient, and so they're probably going to get like Keppra IV. We can do surgical therapy for a hemorrhagic stroke, and that is going to be like a clipping or coiling of the aneurysm. Basically, what we're doing, and I can show you here with this little guy right here, we put a metal clip around an aneurysm, and it just cuts off the blood supply so that the berry doesn't burst, causing a hemorrhagic stroke. We can also do a coil, and that prevents blood flow going into the berry, and it just like passes by it. It doesn't even go into the berry anymore. So those are things that we can do. The main medication that we're going to do for these patients, a good medication that we're going to do that you need to know, it's going to be nimodipine. That's a calcium channel blocker. That's going to keep control of the patient's blood pressure. Now again, ooh, look, there's a drug alert. Assess blood pressure and apical pulses before administration. If pulse is less than 60 beats, less than or equal to 60 beats per minute, or less than 90 millimoles of mercury, hold the medication and contact the provider. So those are things that you actually are going to do for the patient. Now, I'm going to skip over the assessment and so forth, and I'm going to get into like further acute care. So we're going to monitor the respiratory system very closely. We are assessing the airway patency. They're low on O2, give O2. We're going to suction and encourage deep breathing. And if they are ventilated, we need to do oral care at least 2 hours. That is going to reduce the risk of ventilator-assisted pneumonia. We need to position the patient to prevent aspiration. Dysphagia after a stroke is common, and this can cause airway obstruction as well because they have problems chewing, swallowing. They might not have a gag reflex yet. So those are things that you want to know. The patient's going to stay NPO until dysphagia is ruled out. Your neurologic test, that's going to be your NIHSS test. Also, you check their mental status. You're going to look at their pupils. Are they, is Perla intact? And then any extremity involvement and the strength. We're going to be testing those. And you're going to be testing those pretty frequently throughout your shift. So, muscular system, we're going to do passive range of motions. We can position each joint higher than the joint proximal, and this is going to prevent edema on the patient. Specific deformities on the weak or paralyzed sides may be present, include internal rotation of the shoulder, flexion contractures of the hand, like this. It can be flexion contractures of the hand, wrist, and elbow. External rotation of the hip and plantar flexion of the foot. Subluxation of the shoulder can definitely happen on the affected side. You want to be very careful about positioning the patient. We can use what's called a trochanter roll. We can do hand cones. This is not the same as rolled up washcloths. Arm supports with slings and lap boards to prevent shoulder displacement. Avoidance of pulling the patient by the arm to avoid shoulder displacement. And position leg splints or high top tennis shoes to prevent a foot drop. Now, with cardiovascular, what are we going to do? We're going to do range of motion exercises and your VTE prophylactics as well. We do want to assess the integumentary system because they are going to be more immobile. Try and get this straight for you guys. They're going to be at a higher risk of skin breakdown. So we want to provide pressure relief. We want to do good skin hygiene. Turn the patient every 2 hours. You only want to put them on the paralyzed or affected side for a maximum of 30 minutes. The reason why is because that side is going to be more likely to have more skin breakdown due to the deficits. Okay, let me try and adjust this for you guys. The GI system can definitely be affected. Usually it's going to be because of constipation. So what are we going to do? We're going to encourage fluid and fiber. And we can also do stool softeners. They may need to do bladder retraining, and that can consist of placing the patient on a bedpan, bedside commode, or taking the patient to the bathroom at a regular time daily to establish regularity. They can also put them on the toilet 30 minutes after breakfast to stimulate that, the movement of the GI system, that peristalsis. Incontinence can occur. You want to avoid bladder distension. So you're going to palpate the patient's lower abdomen and see if they need to go to the bathroom. You also can put them on a bladder training schedule, have adequate intake of fluids from the hours of 7 to 7. You can have scheduled toileting every 2 hours. Observe for signs of restlessness, which may indicate the need for urination. Assess the bladder for distension by palpation. Also, we can encourage patients to wear pants without drawstrings, without buttons or zippers, because they're not going to have the dexterity. And so we also want to do post-void residual to make sure that they are not retaining. So nutrition, you need nutrition to heal, and you definitely need it to heal after a stroke. You might need to adjust their fluid and electrolyte imbalances that are specific for the patient. They might need to be on enteral tube feeding or parenteral tube feedings. They're going to be NPO until they are cleared by a speech therapist, and that speech therapist is going to rule out dysphagia, right? The inability to swallow. They'll do a swallow test. We can do a swallow test as well if it's okayed by provider and stuff. Basically, what we're going to do, we're going to try and stimulate the swallow reflex, which is with some crushed ice or just a little bit of ice water, and we're going to be assessing if they have the ability to swallow that effectively. We can thicken thin liquids with like some thickening agents. We want to avoid milk products because that does tend to produce more mucus. We want to do mouth care before feeding patients. It does help stimulate the saliva production. Keep the patient in high Fowler's position even 30 minutes after eating. Place food in the unaffected side of the mouth. Teach the patient to swallow and then swallow again. So we're doing double swallowing. Follow feedings with good oral hygiene because foods can get stuck in pockets. And that food that gets stuck, that can cause oral mucosal breakdown or even cavities. We can work with occupational therapy to get some assistance devices such as a rocker knife, plate guards, or non-slip pads for dishes. And then communication. Oh my gosh, how are you going to communicate with a patient who can't communicate? So the patient's response to simple questions can guide you in structuring explanation and instructions. If the patient cannot understand words, use gestures to support verbal cues. Collaborate with speech therapists to assess and develop a plan of care to enhance communication. Things that we can do: communicate often and meaningfully. Allow time for the patient to comprehend and answer and give that response. Use simple, short sentences. Using visual cues. Structuring conversation so it allows for simple answers by the patient. Praise the patient honestly for improvements in speech. We want to give the patient extra time to understand and respond to communication. We may need to use a picture board. Speech therapist does other evaluations to treat language and communication deficits. And then it's also important to teach the family and caregiver all of these new ways to communicate with the patient because they're going to have to go home with them. Again, this is really going to be helpful. This breaks down information. This communicating with the patient with aphasia. The following are guidelines for communicating to patient with aphasia. Treat the patient as an adult. Keep a single thought or one idea at a time. Don't give them multiple questions at a time. Keep the questions simple or ask questions that can be answered with yes or no. Give the patient time to process information and generate a response before repeating a question or statement. And then do not push communication if the patient is tired or upset. Aphasia worsens with fatigue and anxiety. So those are good things to know. So sensory perceptual problems. What were my biggest takeaways from this? Persistent disregard of an object in part of the visual field should alert you of the possibility of henomenous hemiopsia, the blindness to same half of the visual field that's affected. Arrange the environment within the patient's perceptual field. So as you can see here, this patient cannot see these items here. So you want to kind of shift these items so that the patient can see them. Otherwise, they're going to neglect it. They don't know it's there. Weak or paralyzed extremities are carefully checked for adequacy of dressing, hygiene, and trauma. Meaning, the patient can completely forget to dress one side of their body. They can also forget to do hygiene on one side of the body because they either don't see it, they don't feel it, there's a neglect that's going there. Safety measures include closely observing the patient, elevating side rails, lowering the head of the bed, and using video monitors. Avoid using restraints in soft vests because this is going to agitate the patient. It's going to make him even more confused. Because of diplopia, we might need to use an eye patch. We can do artificial tears or gel to maintain the efficacy and the integrity of the eye. Now, coping, that's a huge thing. How do you cope after a stroke? So patients can definitely have fear, apprehension, denial of the severity of the stroke. They can have depression, anger, sorrow. So they need to have that emotional support. Things that we're going to do, we want to update the family daily about what is going on because things are going to change day to day and they need to know. Social services can be very helpful, especially when getting the patient geared up for discharge. They might need some assistance, and social work can help find that. Keep questions simple and then present one thought at the time. And then we can use demeanor and touch to convey support to the patient. Sometimes they do need that touch. That goes a long way. Ambulatory care. What this means, ambulatory is not up and walking, it is outpatient. It's outpatient. So we're getting ready for the patient to go home. They can go home. They can go to intermediate or long-term care facilities or a rehabilitation facility. So as we're gearing up, we want to, as nurses, it absolutely is our responsibility to evaluate the transition plan for any barriers. Is it actually realistic or not? Those are barriers that we're going to be looking at and addressing. We want to identify and provide community resources to these patients and their family, as well as group support, spiritual assistance, respite care, adult daycare. Now, respite care can be for caregivers because they can have caregiver burnout. So that's something that we do want to allow the family to be aware of that, yeah, respite care might be an option for you guys. Rehab, they're going to need rehab afterwards. So they can recover in the first 6 months after a stroke with a maximum benefit of 1 year after a stroke. And again, that's going to very much depend on the severity of their stroke. As a nurse, you can facilitate the process and are often the key to successful rehabilitation efforts. If muscles are still flaccid several weeks after the stroke, the prognosis for regaining function is poor, and care focuses on preventing further loss. Most patients begin to show signs of spasticity with exaggerated reflexes within 48 hours after the stroke. Spasticity at this phase denotes progress towards recovery. Balance training is the first step. This begins with the patient sitting up in bed or dangling the legs over the edge of the bed. They might not be able to really support their posture. So we can improve that support with pillows or cushions that are surrounding them, helping them prop themselves up. Assess whether the patients auto-correct their posture when sitting on the edge of the bed. If the patient can straighten their posture instead of leaning to the weaker side, the patient may be ready for the next step of transferring from the bed to the chair. So when they're able to correct their posture, they can start practicing transferring from the bed to the chair. And that's how we do that. They may need canes, braces, walkers just to assist with mobility. This is also going to include physical therapy to help the patient gain strength. Now, in survivorship after a stroke, there can still be anger and frustration due to the loss of independence. They can have fear and they can be depressed because they think they might have another stroke or even die. And that's a legit fear, right? Don't brush that off. Patient, caregiver, and family need help coping with the losses of a stroke. Provide assistance by supporting communication between the patient and family, discussing lifestyle changes resulting from stroke deficits, discussing changing roles and responsibilities within the family, being an active listener to allow the expression of fear, frustration, and anxiety. Include the family and patient in short and long-term goal planning and patient care. Supporting family conferences and identifying support groups and referrals as needed. Stroke support groups in rehabilitation facilities and the community are helpful in terms of mutual sharing, education, coping skills, and understanding. Significant burden can be placed on the partner of the patient just because now they are picking up the deficits that the patient now has. So we want to be looking at the caregiver as well and make sure that they're okay too. They're just as important. Patients who've had a stroke, they can have inappropriate emotional responses. They can be apathetic, depressed, fearful, anxious. They can be weepy or frustrated. They can have exaggerated mood swings and they can burst into tears or laughter, and you don't know why. It might be the inappropriate response. But when this does happen, you do want to let the patient's family know that this can definitely happen. So if they do have inappropriate emotional responses, we can try and distract the patient. We can explain to the patient and family that emotional outbursts can occur after a stroke, maintain a calm environment, and avoid shaming or scolding the patient. So this is how you want to break down the book. And then let's look at our notes. So, medications for ischemic stroke. It is going to be TPA if the signs and symptoms are 3 to 4 hours 3 and 4.5 hours within reaching the ER. We want to maintain the blood pressure above 160, and we're going to give seizure medications. For hemorrhagic strokes, we're going to give nimodipine. We can clip or coil an aneurysm as well. Either way, we're doing the NIHSS assessment. We're checking for any current medications that may have caused a stroke or may be mimicking a stroke. We want to look at any medications, like if they're on any anticoagulants already, recent injuries, recent illness, health history, baseline cognition. What's their baseline cognition? Is this normal for them or is this not? The number one cause or risk of a stroke is hypertension, and we want to advocate for smoking cessation. That's going to be a part of your health, like your health promotion. And then I'd like to go into RN care. CAB is your priority. Circulation, airway, breathing, priority. Patient may need to be intubated, especially if there's no gag reflex. They're going to be NPO until dysphagia is ruled out. They're going to have frequent neuroassessments. We're going to monitor their vital signs, slap on an EKG or even a telemonitor. VTE prophylactics, we can do, if appropriate, we can do, they're going to be on some blood thinners, especially if it's a ischemic stroke. Not if it's a hemorrhagic stroke, we're not going to do that. But we can do range of motion exercises. We can do TED-HO stockings, those SCDs, stuff like that. Position each joint higher than the other. Patient can have internal rotation of shoulder, flexion contractures, and of hand, wrist, and elbows. They can have external rotation of the hip with plantar flexion of the foot, and then subluxation of the shoulder can occur. We want to use a trochanter roll, hand cones, arm supports with sling. We can use lap boards. Do not pull by the arm, especially the affected arm. We can do posterior leg splints or high top tennis shoes. Meticulous skin care. Turn every 2 hours and then only put the patient on their affected side for 30 minutes. They got constipation, we're going to treat the constipation. We're going to give them stool softeners, fluids, fiber. We may need to do bowel scheduling. And a good thing that was brought up was that 30 minutes after having breakfast, you can put them on the toilet. If they have incontinence, we can try and avoid overdistension. You can assess for retention with post-void residual with a bladder scanner. Give hydration during the hours of 7 a.m. to 7 p.m. If they get restless, assess for the need to use the restroom. Nutrition, we broke it down quite a bit. Communication, assist with any spatial neglects, remind the patient to dress or have to shave clean on the neglected side, arrange food objects on the unaffected side, do eye care, rehab, most recover within 6 months to a year, and so forth. So we've broken down all of that information, all of these pages that we just went over, right? This is quite a bit of pages. There's more, right? We went through a whole lot today. And you broke it down in only a couple pages of notes. And that's how you go about using the book and creating notes. Now, what's the biggest and most important thing about the textbook? It's learning how to be a nurse, learning how to assess these patients, learning the medications and treatments that we can do, and then knowing the nursing care. So hopefully this helped today. I hope you guys got something out of this. I'll continue making these videos. They won't be as long as this one. This was just a particularly long chapter. But I hope you guys have a great day and take care.